Get started.
Whenever you're ready.
Okay. Good morning. Welcome to the 20th Quantitative Imaging Workshop. This is our second day. We appreciate everybody who spent the day with us yesterday. It was packed with interesting things. No, it was quite remarkable. It was interesting to hear the updates to the guidance policy from the American Cancer Society, especially when they're simplifying and expanding eligibility criteria with an expectation of potentially recruiting 5 million more at-risk individuals to undergo screening. So with 19 million screening subjects potentially possible, it's a very important time to consider, what are we doing? How are we doing it? How can we work together to make sure that we have the capacity to meet all the needs of the chain of events that need to be in place for screening to be done in a high quality way for everyone in the United States and hopefully throughout the world who is in need of such services. So we had a very, very interesting discussion. Benefited from a lot of international perspectives yesterday as they share this problem of implementation. We had a very nice award ceremony in which we honored the contributions of Matthias Utkirk and his talented colleagues in the Netherlands and Belgium who have brought forward the validation trial with the Nelson. And now, as we're hearing, are moving forward in very interesting ways in the cardiovascular option to evaluate coronary calcium in the chests of individuals undergoing lung cancer screening. This echoed the efforts of Dr. Morton Agavi, who's been with us before, who has talked to us about progress in cardiovascular calcium imaging in the United States, which is a very dynamic field. Our initial session today, we're gonna follow that thread and look at where coronary calcification is moving in relative to the screening opportunity. And we're looking forward to comments, the discussion in that regard. And then that will be followed by a policy finance discussion of cost implications of screening and how we can potentially make sure that innovation that is required to really make this a mature service can evolve and move forward to be available to everybody to make the screening process better, cheaper, faster. And then finally, we'll finish up in the afternoon, we'll finish up the breakout groups where we'll have cross discussions from all the sections and look forward to focusing both on clinical issues and on technical issues. And then that's the end of this workshop. However, as you know, one of our big efforts is to identify action items, and we'll try to distill them in the process of our breakout activities, and we'll be planning on how to move forward with those activities in the upcoming year. So without further ado, I'd like to turn it over, and we have a very wonderfully accomplished staff of faculty working with us on the next session. And Dr. Yankelevitz and Matt Cham and Tochi Okwuosa are going to help us with moderating. David, can you take that from here?
Yes, Jim, thank you for the introduction. I'm going to be co-moderating this session, although I'll be mainly focusing on the latter two. I think we're going to have 3 hours of cardiac imaging here, which I am very excited about because I think the value of cardiac imaging in the context, especially of lung cancer screening, is, I think, going to be exploding over the next few years. There's been some tremendous progress. We've already heard some of it yesterday in the keynotes talk by Dr. Nagavi, and I know that Professor Utkirk has some exciting results possibly to tell us, or at least tell us some of the progress that he's made in his Rubinska trial. and his experience as well. We'll talk about each of these sessions when they go into more detail for each session when they start. For the first session, Matt Cham is going to be leading us. So Matt, take it away.
Thank you so much, David and Jim, for that introduction. So to kick off our session on clinical optimization of lung cancer screening, CT for coronary artery calcium Theragnostics, we have Dr. Fei Lin who will be giving us a 15-minute overview. Dr. Lin focuses her research on imaging of coronary atherosclerosis to guide prevention of adverse cardiac events using coronary CTA. She trained at Weill Cornell for her cardiology and imaging fellowship and is currently clinical associate professor at the Icahn School of Medicine at Mount Sinai. Dr. Lin has extensive experience in clinical trials, including CONFIRM, a prospective observational cohort registry of 27,000 patients undergoing clinically indicated CT and followed for outcomes, the ICONIC trial, a nested case control study from 25,000 patients who underwent CT and followed for occurrence of acute coronary syndrome, and the PARADIGM study, which is comprised of 1,255 patients who underwent serial CT imaging for evaluation of atherosclerosis progression. She has also been involved in numerous other trials, including the CONSERVE, CREDENCE, FFR3D, Discover VP, and COVID CT trials. So without further ado, here's Dr. Fei Lin.
Thanks very much. Share my screen. So my task today is to talk about clinical optimization of cardiac CT, lung cancer screening CT for CAC Theragnostics. And I did have to look up what CAC Theragnostics meant just for the purpose of this study, as I have no disclosures. So why is prediction of CAD important for preventive therapy? It's because the initial presentation for 50% of patients is fit MI or death without presaging symptoms. And that's because if you look at the underlying coronary stenosis prior to the MI, the majority of them are actually non-obstructive. And so how do we do that? Well, currently we do it with conventional risk screening and scores. And we use this to impact preventive therapy because we're trying to balance the benefits of risk reduction with the adverse effects and costs of preventive treatment. And RCT data for lipid and for antiplatelet therapy is really only there for high and low risk patients. And actually for intermediate risk patients, those benefits are unknown. And so how do those non-obstructive plaques cause MI? Well, it's because what causes plaque rupture is this kind of vulnerable plaque. Vulnerable plaque has a large necrotic core full of lipid with crystals and inflammation. And then the inflammatory cells within the necrotic core eat away at the thin fibrous cap. Here are macrophages. And then it's the death of these macrophages that causes calcification. And so in fact, the calcification that we see is actually an integrated history of plaque progression. It's the detritus of plaque and not the most important part of the plaque itself. And the big picture of plaque progression is that as we accumulate lipid, we're also continuously trying to defend our body against it. And we're calcifying the lipid pool like an eggshell until we turn our atheroma into fibrocalcific plaque. And fibrocalcific plaque may be symptomatic. It may cause stable angina, but it no longer has the potential to rupture. And that is really the threshold at which we start to see it with coronary artery calcium scanning when it starts to become macroscopic and large, and not when it's in the microscopic stage. And so what does that mean for CAD primary prevention? Well, these are the current ACC/AHA guidelines. And the big picture is that the only group that's really indicated for CAC scanning is here. So this is very tiny. I'll go through the major groups, right? So kind of what it's saying is if you are only really indicated for screening if you are middle-aged. If you have familial hyperlipidemia or diabetes, you go off into a different category. If you're elderly, you go off into a different category. And then only in this middle-aged patient population, you would calculate an ASCVD risk score. And then in these low risk and borderline risk patients, which is up to 7.5%, or in these high risk patients, then they have an indication for therapy. And in these intermediate risk patients, then coronary artery calcium can be used either to risk reclassify them down if their CAC is 0, or risk reclassify them up if either their CAC is greater than 100 or it's greater than the 75th percentile for their age group. And primarily, this is just for statin therapy. And so what are the differences when we're thinking about CAD primary prevention from lung cancer screening? Well, the first is that many patients will have indications for treatment even without the CAC, that patients have competing risk factors to think about besides the CAC, that the treatment itself of statins will increase CAC, and then that also sometimes the benefit to the patient is not in taking more medication, but actually less, because with age and 1 to 2 risk factors, most older adults have an indication for statins, and the CAC of 0 is there to reduce polypharmacy and not to intensify treatment. So the CAC DRS also has a set of recommendations. The CAC DRS kind of couples those strata of Agatston scores with the visual score, and then directs a treatment recommendation where a 0 is statin generally not recommended, 1 to 99 is moderate intensity, 100 to 299 is moderate to high intensity with aspirin, and then greater to 300 is high intensity statin with aspirin. And these guidelines are a little bit different. And in fact, the guidelines, when you look around the globe, are all very different. In some of the common indications are generally that the age is greater than 40, the risk is intermediate, and then you're looking for an asymptomatic population. And then some common treatment thresholds are a CAC of 0 or 100. But there's really a lot of non-agreement, for CAC for any other medication prescription or for any other potential thresholds. And so the challenge for Theragnostics, which is a treatment strategy that combines therapeutics with diagnostics, is that right now recommendations from these guidelines are not supported by trials. There aren't consistent recommendations for thresholds of treatment. There are no consistent recommendations for what treatment should be given. And actually, since these kind of thresholds have been suggested, we have trials that say aspirin can cause harm in the elderly. And finally, it's we need to know whether or not we are actually addressing the right primary prevention population. Because in diabetes and familial hyperlipidemia, they need statins regardless of CAC, or in a symptomatic population or a secondary prevention population, then they go into a completely different clinical algorithm. And so what are some common thresholds for action? Well, it could be 0. We could use population nomograms. We could use a calcium score of 100 because that generally corresponds with a greater than 10% 10-year risk. Or we could personalize it. It could be integrated into the clinical risk score for a 10% 10-year risk. And so let's look at each of these thresholds. So CAC of 0 has a very high negative predictive value for events. That's why you can take patients off statins. So with the CAC of 0, you generally see a CVD event rate of less than 0.5% over 5 years. And so then you're definitely below the threshold to go on statins. Now, what's important is also that extremely low density calcium in CAC of 0 is still a adverse prognostic sign. So in the MESA cohort with CAC of 0, which was actually the majority of MESA, a calcium scoring compared to a phantom instead of to the absolute threshold of an HU of 130 was still risk stratified patients. And so this is important to report and maybe something that could be overcome with AI. The MESA study provided population-based normal values age 45 to 75. And so this is part of the recommendation for reporting for CAC. And so you can see here, you enter the patient's age and sex and Agatston score, and it spits out their percentile. And that's how you say, are you at a 75th percentile for, and therefore at an increased risk for your age. That can also be entered into an integrated risk score. So these are all of the factors that are in the pooled cohorts equation for risk scoring plus the CAC. And so this is how you can achieve an individualized risk score. So if we look through the kind of nitty-gritty of how you get a standardized Agatston score, then we can think about the application to lung CT. So the population is asymptomatic, primary prevention. Acquisition is at 120 kV with 2.5 to 3 millimeter slices, gated. Scoring focuses on the coronary arterial silhouette. It's very easy to add aortic or mitral calcification or hardware with inexperienced hands. To reduce noise, at that time, they are looking for 3 contiguous pixels with a peak attenuation greater than 130, and then each voxel is assigned a weighted sum by HU. So then what are our considerations when we're trying to transfer it to a different patient population? Well, the first is, how do we identify the right patient population to which CAC applies? Who's the primary prevention population? Who are the diabetics? Who are the familial hyperlipidemias? Who do you calculate an ASCVD risk in? And so this may require integration with electronic health records and large language models for abstraction of text. The second is acquisition. So what's the model generalizability to a different KEV, to a different scanner with a different reconstruction protocol, to statistical reconstruction that changes the voxel noise? And the second is, of course, motion, because with motion, you can have misclassification of CAC equals 0, and we're going to come back to that in a moment. And then the last is the actual nitty-gritty of scoring. So what's the model generalizability in difficult cases with hardware, with non-coronary calcification? Can you recognize a stent so that you know that you're not scoring somebody where CAC scoring doesn't apply? Can you automate integration of the risk factors into a risk score? How do you look for statins? And then also, how do you explain it to referrings and patients? So in past studies with human evaluation of ungated CT, usually you have a pretty high correlation. But one key thing is that the false negatives for calcium scores can be they can be low or high in different studies. And so that's an important consideration because that's often one of the key decision points. Here's another consideration. Think about statins favor the progression of high density of 1K plaque. So it actually increases your score. In the paradigm study, in patients who had serial CT and then a known statin history, you can see that statins reduce the non-calcified plaque. Here in orange are the patients on statins, and in gray, the ones who were not. And so you reduce your non-calcified plaque, but your calcified plaque actually increases. And then the kind of low density calcium doesn't really change. And so, your reflection of what's going on with your atheroma may not be in the score. And in fact, higher density calcium is protective against ACS. In the Icahn study, when we retrospectively looked at patients who had ACS after their CT compared with controls, if we looked back at their baseline CT, the patients that had this high density 1K plaque were actually more common in the controls than in the cases. So it was actually protective. And then can we use explainable ML to tailor care? So in the CAC consortium, of asymptomatic subjects, when you apply SHAP analysis with an XGBoost model for all-cause mortality, of course, this is not deep learning. This is just garden variety machine learning. You can see that you can individualize for a particular patient what is the meaning of a particular risk factor. So here's a subject where the impact of CAC density is high. This is a young woman with a CAC of 1. The average prediction for her population, for the entire population, is here. She is elevated in her prediction compared with the population. And what's the most important thing that gets her there? The SHAP analysis calculates the attribution to different risk factors based on a game theoretical model. And so her greatest risk comes from the CAC density. And then meanwhile, here's an older man with a CAC over 1,000. His predicted 10-year mortality is 35%. And then he has multiple other risk factors, including age and smoking. And so in this person, the CAC density has a very low impact on the prediction. And so this may be a way for physicians to prioritize which risk factors to address. So some major considerations for AI-CAC. Let's apply it to a recent article coming from Stanford, where they applied a deep learning CAC algorithm on retrospectively on non-gated chest CTs between 2014 and 2019. And they were able to see that they were able to identify CAC of 0 in 50% of patients. And then also that a CAC of 100 increased the likelihood of all-cause mortality and cardiovascular mortality. So we'll look back and say, okay, what are those considerations? First of all, did they find a primary prevention population? Well, they did. They excluded outside referrals without pre-CT encounters. They excluded existing ASCVD and metastatic cancer with chart review, and then they calculated the ASCVD risk. And so, when we're considering how to apply this to lung CT, how is that going to happen for these patients? How are we going to make sure that this is a patient population where that even applies? What about acquisition and generalizability? Well, this was really only tested on the Stanford healthcare group. So it's whatever scanners and protocols they had. They did previously test it on 6 external cohorts for generalizability. And then they said in that group, they had a positive predictive value of 93, sensitivity of 95. And that means the false negative CAC 0 rate is 5%. And so again, that's, are you going to be falsely taking away statins from patients where they actually do have some calcium? What about scoring integration into treatment? Well, we don't really know the performance in these kind of ED cases, say with valvular calcium, but in their original paper, their training set was pretty small. It was, and so you don't know whether whether these particular model could overcome valvular calcium if it wasn't really in the training set. And also it was retrospective. So communication and therapy played no role in this study. Communication and maybe one of the most important aspects, in fact, of calcium scoring. So this is the Eisner study, which was a study maybe more than 10 years ago of 2,000 patients of risk factor counseling with and without CAC. And patients were randomized to CAC, and then they both case intervention and non-intervention patients went to a specialty clinic where risk factor counseling included showing the patient their coronary calcium. And the primary endpoint was improvement in risk factors. And they showed that they improved the blood pressure, they improved the lipid profile, and they improved weight control. And now this is very interesting because these are not these are things that take maybe years and years to improve, right? Like blood pressure is something where you need to titrate medication. Weight control is something that requires self-control. This is something where a lot of the impetus really came from the patient and not necessarily from just the physician. And then also their Framingham risk score endpoint was that there was a lesser increase in Framingham risk score in the intervention patients. Now, what happened to cost and downstream care? Well, there was no change in overall costs because in the low CAC and normal patients, they had reduced medication and procedure costs. And then in the high CAC patients, they had increased costs, not because of bad outcomes, but because of downstream medical testing. So 2/3 of the patients with CAC greater than 400 went to stress testing and then had downstream testing. Now, and on the other hand, it did reduce downstream ICA and revascularization. And so when we look at population-based screening trials, Dr. Erdkirk is going to address the Rubinska study, but the Rubinska study is an ongoing study right now where of population-based RCT of CAC. And then we can also look at the Dunkavis trial. This was an RCT of population-based screening with coronary calcium, ABI, lipids and diabetes screening, coupled with treatment in a specialty clinic. And this was only in men, 65 to 74%. And many patients did not complete their screen. And what they observed is that screening was increased antiplatelet and statin prescription. It didn't really change adherence. And then there was no difference in CV outcomes at 5 years. The 10 years pending, with a subgroup benefit only in men 65 to 69. And so what's missing here? Is it showing patients their risk score? And so, especially as we think about what can we use in the future for risk prediction, you know, we saw yesterday, there's calcium score, there's calcium density, the calcium distribution is important, chamber quantification, LV mass, the thoracic, aortic valve calcium, epicardial fat, these have all been demonstrated to have incremental prognostic value. But then what do we do with it? First of all, what patient population does the risk factor apply to? What's the generalizability of the risk score to this patient? What's the pre-test and post-test probability? And then what's the treatment? How do you treat epicardial fat? How do you treat a dilated left atrium? And then also, in many patients, is treatment indicated regardless of imaging? And does the treatment, say for epicardial fat, actually reduce risk? Is risk reduction with treatment reflected in imaging? And then how do we couple it with treatment? What threshold, how to communicate with the referring, and how to explain with the patient? Because in some ways, you know, probably what was very convincing is that seeing is believing. Seeing this little white thing on your own heart is a way to really personalize care to the person who really is the going to be at the end of the day the driver of the entire show. So. So those are, I think, the things we should think about as we move forward with utilization of lung CT for coronary risk stratification. Thanks very much.
Great. Thank you so much for that wonderful lecture, Dr. Lin. It was very insightful and truly engaging. I'm just going to share my screen over here so we can continue our discussion. Hopefully my screen is coming across. So we're going to have a panel discussion now, which will include Dr. Lin, Dr. Oudkirk, who needs no further introduction. He's the recipient of our Jim Mulshine Leadership Award yesterday, and Dr. Nagavi, who was our keynote speaker yesterday as well. I just want to start off this discussion talking about the clinical parameters that we may or may not consider when we're talking about collecting calcium scores from lung cancer screening specifically, which is a chest CT, not even a dedicated cardiac CT. It's a very hot topic because clearly, if you're trying to use chest CT to evaluate coronary calcium, it's not the perfect test. The question is it good enough? And what are the things we need to change to make it good enough and to be actually practical to apply in daily practice? So I'll also be co-moderating this with Dr. Tochi Okwuosa, who's online right now as well. So in terms of the clinical parameters, one of the things that we know will affect calcium scores is heart rate, and that's not something that we routinely collect on chest CTs. And clearly, the faster the heart rate is, the more blurry the calcium score or calcium images will be, and so it can affect the score. The question is, would knowing the heart rate really help us determine whether the score is believable? And if we knew the heart rate was, say, 85 or 90 in this patient, what would we do with that score anyway? Would we actually modify it or create some kind of correction factor for that score? So I'd like to open this to the panel to hear what their thoughts are and whether, again, it's data that's worth collecting or whether it's extraneous data that will be useless even if we collected it. So Dr. Lin, Dr. Oudkirk, I think Dr. Nagavi may not be online yet, or also from Dr. Okwuosa, if you have any thoughts on that in terms of collecting heart rate and whether you think that data would be useful.
Well, I can comment on this. We collect all of those and more, a lot more, but the relevancy is of course different. And in the beginning, the heart rate was extremely important because the systems were very unreliable with higher heart rates. And then, of course, depending on the heart rate, we would apply medication to lower it down with beta blockers. And the calcium score would only be reliable with systems that are currently available. So most systems that are used for and that's a problem for lung cancer screening, would need ECG triggering and would need beta blockers to lower down the heart rate and make at least the measurement a little bit more reliable. Otherwise, all those that have a heart rate higher than 60, 65 in the systems that are, I think, in 80 or 90% used in lung cancer screening, will render really unreliable results. So that is something extremely important, and depending on the system that you're using. So that's the key here. Height and weight is a standard thing, I think. Race and ethnicity is, of course, also a standard thing, important for everything we do in terms of study. We know, of course, that if you would like to stratify the risk to the ethnicities, we know, of course, that there are some ethnicities with an extremely highly increased calcium score at lower ages. So this is all very relevant to know. And the medication is, of course, also important to know. Here you mentioned beta blockers. Now, I mentioned that the beta blocker is important to have in place at the moment that you have higher heart rates in 90% of the systems that are used for lung cancer screening, and that's also something we should debate. Then you also have to do ECG triggering. That would give you, you really need trained personnel to do a good ECG triggering for the test, and integration with lung cancer screening. And the other things are more sophisticated. I think diabetes is important to know. We know, of course, that you have quite a lot of high increase of calcium score in diabetes. But on the other hand, it's important to realize that there is a category with under diabetes patients which have a 0 score. That's, you don't understand it, but that's what it is. So the far majority will have a highly increased diabetes. Diabetes patients will have an increased and high calcium score, but there is still a subset of something like 10-12% that will have a 0 score. And then the calcium change over time, that's a very difficult issue. We have quite a lot of information on this, and we think that under treatment, probably the calcium is stabilizing and not really going back. So our initial idea was, when we tested this, that under the treatment it would really change. Perhaps the density, as has been already discussed by Nagavi yesterday, probably the density changes, and under statins it get more dense, so it gets more stable. But that is still report on casuistics, so there are no large studies that prove this. And it's also important that we, from our registries, we find that if you come in a calcium score over the 1,000, the mortality is not really increasing anymore. So that also points out that there could be a kind of stabilization. In the overall comment on the calcium score, it developed, of course, in what we called the oculostenosis of the cardiologist. So it's still there. It's especially it's now changing in the US. but it's not that much changing, for example, in the Eastern countries and in Russia, that they just treat every stenosis. So you see a stenosis, you treat it, and the problem is fixed. And that is also something that is here in the calcium score that we think that it really shows something that is relevant for the stenosis itself. But probably the calcium score is a record of events in the past. And it tells, so if you have many of those calciums, then you get an increase of the score. And then also the chance that you will get a next, and I call it micro events, in the intima with minor bleedings. If you look at the enormous change in shape with every heartbeat of the coronaries, it's unbelievable that it can function that in billions and billions of heartbeats in a lifetime that it can function and that is not rupturing. And probably there are micro ruptures in the intima with small bleedings that calcified, and that gives it. So those are past events that we are looking at, and it is not, and it is more or less, an indication for the events that will come. So at a certain age, if you have no zero score, then you had no event that lead to bleedings in the intima, and that also gives you a high chance that in the future you will not get anything. So that's the relationship. But what really matters is the perfusion of the muscle. So, and that is where we are focusing on. We have running studies on this, and we have already some information on this from the first 600, or we have now, I think, 1,000 included. And there we are looking to patients with a higher score than 300, completely asymptomatic. And in those patients, we do a perfusion MR. And we find that we have inducible perfusion defects under around 30% of the patients if you have a calcium score higher than 300 in this study. So there is a relation in asymptomatic patients with a increased calcium score that you have inducible cardiac perfusion defects in this patient category. But it's only in 30, or only, it's around 30%, perhaps a little bit lower, but it is there. And those perfusion defects really predict that there can be a larger infarct. And what is important to know is also that if you have a negative perfusion, so we published quite a lot of studies on the perfusion of the cardiac muscle. If the perfusion is normal, that is the best prediction that there will be no cardiac infarct the coming 10 years. So I think we should think in that terms. And then okay, for now, I think I said already more than enough. So I give the word back to you, Matthew.
Thank you so much, Dr. Oudkirk. You touched upon several very important points there. And I'm just curious, one of the things you mentioned is that you administer beta blockers in patients with high heart rates. And I just wanted to clarify, do you give beta blockers during lung cancer screening CT? Because that's something that I haven't heard.
No. We did this in those studies. So the Rotterdam calcification study, and also in the we used ECG triggering, and in very high heart rates we also used beta blockers in the Robinska study.
I see. Excellent.
Yeah, because we were extremely focused on reliable calcium scores.
That makes a lot of sense. Thank you for clarifying that. The other question I had is in terms of ethnicity. So the largest databases that most people use are the ones from the MESA trial, which has the ethnicities of white, black, Chinese, and Hispanic. And we always have trouble at our institution, and I hear from other institutions too, when patients are from demographics that don't fit those four categories, like Middle Eastern patients or patients from India or Pakistan, Southeast Asia, where they don't really fit Chinese, but they don't fit Caucasian perfectly. I'm just curious what you usually do for those populations, Middle East or people from India, Pakistan, when they don't fit the 4 MESA demographic categories.
Now we are living here in the Netherlands. So that is something you probably cannot really realize. We have no percentages that can lead to any to any conclusion. So I have to yeah, I really cannot answer on this question. Only from casuistics. So we know, and there in casuistics we know that the ethnicity plays also in those cases a very high role in terms of high calcium scores. I think there the MESA study is really the most informative study on ethnicity. I would like to make one comment on the MESA study. There's another very important point on this, that everything that has been, we will come to this point later, there's a very important thing about the MESA study, that this is performed with EBT. And that's an electron beam tomography system. And that is where we did our studies also with. So we did our studies, the Rotterdam calcium study is done with EBT. And EBT goes down even lower in a temporal resolution, even lower than 50 milliseconds. And that is not available in only in the systems that we are used for the Robinska, and now we're using for lung cancer screening. There we go also near to this 50 milliseconds temporal resolution. But that is, the EBT was already there before 2000 even. So this is a benchmark study, the MESA study, that can probably not be repeated anymore, because those EBT systems are withdrawn from the market by GE. So they bought the company and then killed the system. And that is really very, it's a pity, because I think for cardiac purposes, it is a non-mechanical system where you rotate the electron beam around the patient instead of a complete mechanical stuff, what we are doing now. And for this very accurate measurements, so that was also very nice. You had around 150 of those systems in the US. And with those systems, you had an extreme high standardization. So all the systems were extremely, there was no difference between the systems in terms of KV, in terms of the measurement protocols, acquisition protocols, everything was the same with those systems. And therefore, the data of the MESA study are very reliable. We worked, I did in my department the only comparable study with dual source systems and EBT. We published on this because we wanted to prove that we could come with dual source systems with ECG triggering and beta blockers to the same results as were just available with the EBT, so that we could translate all the research output from those studies that were done with EBT also to CT systems. And all the later systems that we are using now have not this high quality. So it's very difficult to get at this moment comparable data that has been provided by the MESA study.
Absolutely, that's a very important point. And I was actually going to bring that point up too, that dual source CTs have been available now for almost 2 decades, and it may be worthwhile to consider performing.
No, only 10 years, only 10 years.
Only 10, I think, since
12 years.
Right?
I had the very first dual system in the world, so I know the exact date. So that was the definition, and it was in 2009, if I'm correct.
2009, I see. That makes sense. And given that the dual source CTs have a much higher temporal resolution, it might be worthwhile to consider performing this calcium analysis only on facilities that have that scanner. Again, just for the sake of uniformity. The issue with that is that some institutions may not have that scanner and therefore will not be able to participate in any studies that involve that level of precision. So before we run out of time, I just wanted to open up the floor to any comments from Dr. Okwuosa or Dr. Lin regarding this topic of clinical parameters as well.
I would just say that I do agree with Dr. Utkirk quite a bit, especially with the issue of heart rate. You know, I'm a cardiologist, and I know that if the heart rate isn't controlled, you're getting very, very unreliable data. And it's one of those things, if a patient of mine has a heart rate in the 80s, you couldn't possibly send them from coronary CT without putting them on a beta blocker or something like that. I would say that and I also agree that the rest of the parameters that you mentioned here, height, weight, race, ethnicity, the medications, diabetes, all of that, I think are necessary for data collection, because that is how we're going to be able to understand a little bit more, depending on what the demographics are, how medications influence data and so on. So I think collecting all of the above is very necessary from a research standpoint. Dr. Utkirk, and then the last point, CAC change over time, adjusted for the above conditions. I think that one is a little bit tricky in the sense that if you had a CAC of 0, you're not going to place them on a statin therapy. And maybe it would be necessary, maybe in the next few years, to see if they have CAC development of CAC or new CAC. I think that's great. That's important. But if somebody has a CAC score that's elevated to any extent, and you're going to put them on a statin therapy, and statin is either going to stabilize the amount of plaque or actually the amount of calcium, or actually make it worse, then what is the point in looking for change over time in calcium score? So I think that part is a little bit tricky. Maybe CAC development is a better parameter to look for in that sense. But again, if you're including statin information, then that's useful. Dr. Utkirk, I had a quick question for you. So based on the study that you were talking about with cardiac MRIs versus CAC scoring, you were talking about CAC score greater than 300 and then getting MRIs in those patients and assessing perfusion. Are you saying that perfusion with the cardiac MRI is more prognostic than the elevated calcium score?
No, not with MR, generally. So the perfusion of the cardiac muscle is the ultimate predictor for coming events. So if you have no inducible, so you stress so the way we do it, we do stress perfusion. So we have a rest perfusion, you compare it with a stress perfusion, and if there are no inducible
ischemia,
then there are extremely nice studies that give you the prediction that the chance that you will get a cardiac infarct over the coming 10 years is neglectable. So that's the ultimate test, and you can do it with. That's different stuff. We prove that MR perfusion is the best way to do it, and better than nuclear perfusion, and better than CT perfusion for all kinds of reasons. We have no time to discuss this, but I know that in the US they do everything with nuclear perfusion, and nuclear perfusion is really very insensitive. So that is why we did this new study with cardiac perfusion with MR. And the inducible ischemia that we find with MR is, in a majority of cases, not, you cannot visualize it with nuclear perfusion. So that is far more sensitive. And I think it would also be extremely important in the cardiac community to promote MR perfusion. So for this reason. There's no radiation. You have an extremely high temporal resolution, which is not comparable to anything else, except for ultrasonography. But ultrasonography is, of course, not really applicable in a standardized fashion in large cohorts. So we think that there should be a major application for MR perfusion in the future. And then finding the relation between the calcium and the perfusion of the cardiac muscle is one of the most important things, and that is why we are focusing already for I think 15 years on the relevance of the zero score. And I find it very nice that you mentioned that the zero score is can be quite unreliable, and because that's very important. And we find now in the Rubinska study, so I can tell a little bit about the Rubinska study. That's in 40,000 participants. We included them all already more than 5 years ago. We just got 2 weeks ago the final connection that we need for the mortality rate with the national registry. So you have long waiting times before you get this information. And now we have the information of all the participants, if they died, and what the reason of death was, and so forth and so on. So now we can really connect the 3 groups where we stratify them in. That is one, just the GP standard treatment of those patients with that were randomized. Then one group that is treated according to the calcium score. And then one group that is treated according to the score chart that is comparable with the Freeman score in the US. And the end of this study, the primary endpoint of the study is mortality, and also, of course, MACE rate. And one thing that is extremely important is the 0 score, if this indeed predicts, well, we are quite confident about it, but that we have in 0 scores very low mortality rates. Now, a very nice figure that I don't think that we published it still, but that we find a 36% restratification downstream restratification of patients that would have been treated according to in the other groups with statins that have a 0 score and can be statins can be withdrawn. And we think if we could combine it in a very reliable way, that from a cost aspect, you could more or less, if you combine it with lung cancer screening, you can probably almost pay lung cancer screening from the restriction that you can make with not treating those people that do not need statins for cardiac therapy. So that would be a nice a nice combination if you could come that far.
I just wanted to add, I think when we think about the clinical parameters, we just want to say, besides the individual components, what's the overall goal? And so the overall goal is we need enough data to say whether the patient is an appropriate primary prevention patient. We need to know, or do you have diabetes and hyperlipidemia? We need to know, can we calculate your risk, and are you in that intermediate group? And then we also need to know, are you actually a symptomatic patient or a secondary prevention patient? And I think, when we look down and say, well, what's going to be credible to care providers, as important as reporting it is also not reporting it when it's not appropriate, right? Because I think, otherwise you're drowning the attention of your referrings with data that, is difficult to interpret.
Very important point.
Yep. I completely agree.
Very important.
Please go ahead.
Now, yeah, we are studying this, of course, in the Fern-Lungen study. So in the Fern-Lungen study, we do all 3. So we developed because we only use for this lung cancer screening study the highest end 3rd generation CT systems, dual source. And with this, we can do a quite reliable ungated calcium score. We published also those figures compared triggered versus non-triggered, that you can do it reliably. And with this, we will know the interaction, of course, between the calcium score as a comorbidity, the emphysema score, and also the eczema analysis, you must say, more or less. And then also the lung cancer rate. And then we hope, of course, or we don't hope it, but after 5 to 10 years, we will know what the primary cause of mortality will be in those cases. And if there is a high relationship with the other diseases from the ID that it is all the same factor, and vice versa, are the relationships also that the zero score predicts, more or less identifies healthier persons.
I would just say, Dr. Lin, I agree with you about what you said about clinicians and drowning them with data. But I would argue that as a clinician, most clinicians, if you give them a CAC score, that's all they look at. They don't look at the rest. And all those other parameters, if you're talking about research, right, if you're trying to use electronic health records to do some research in future to understand certain parameters and certain demographics and outcomes and the rest of them, those parameters end up being very important in that sense. But if you're reporting coronary calcium and you include all these other information there, most clinicians would go and all they look for is CAC score 35 and the rest of them don't make a difference. So it's kind of playing that balance between trying to get great information that you're going to use for research now or in future, and then the balance with the clinical aspect of things.
Yeah, I agree. But I think also, I was thinking about those factors more as just whether to say whether we report at all, like to know whether or not you have a primary prevention patient. Because what is the calcium score when the patient says on a form that they've had a stent before, like.
Well, then in that case, the calcium score wouldn't even be necessary at all, right?
Right,
So,
but if they're calculated on every lung CT, then you need to know that you shouldn't calculate the calcium score on that lung CT.
Yeah, but that same question is relevant for the lung cancer screening itself also, because we have many incidental findings which should probably not be reported. So what you're telling is music in the ears of our health council in the Netherlands. They really want, the medical people won't come with your opinion here in the Netherlands. And I think it's extremely relevant remark.
So I think those are all really great comments and very engaging discussion. I just wanted to ask one final question. Since we're at the hour now, this is the end of our session. Since everyone pretty much agrees that heart rate and ECG gating is important for the precise measurement of coronary calcium, given that we don't do these routinely for lung cancer screening for many reasons, cost is one of them, the labor required to even put ECG pads, the cost of ECG pads, all those things add an extra layer of resistance from hospital administrators, for example, given that the reimbursements bare bottoms for lung cancer screening. My question for those of you who are familiar with this test, how many years into the future do you think will it be before beta blockers and ECG gating is performed routinely for clinical lung cancer screening chest CT? In other words, if you had a crystal ball and I were to ask you, what year do you think beta blockers and ECG gating will be standard for lung cancer screening? What would you think that would be? 10 years from now, 20 years from now, or never? Like, what are your thoughts?
My thought is that it will go in the other direction. That we will come to, that everyone will use high-end systems where you don't need those other elements. I think it's also much cheaper at the end to do it with the high-end CT systems than use all those. It induces all kind of new variables, all this work. Then you get all kind of human interactions with unreliable, non-comparable outcomes. I think that it's not a way to go. We are now there, so if you want to combine it, you have to do it. So we do also here in Europe. There are many centers that want to join us, and then if they cannot meet the high standard quality, then we say, okay, then you can only do lung cancer screening.
I agree, and so does Dr. Maron, who just posted on the comment section the word never, meaning never beta block or ECG gate lung cancer screening CT, because AIs will be able to score these non-gated CTs. We also have additional comment from Dr. Lin describing the Masala study with normal values for South Asian. So thanks everyone for all these comments. I think we're going to move on to our next session now, which will be on reporting non-coronary cardiac findings in lung cancer screening CT. Let me just switch off that slide here and share that slide.
Matt, before you get,
Sure.
I think that our speaker has not joined us for this, Dr. Nagavi, who was going to be introducing. I don't know, is he not on yet? I've just been trying to reach him. He was our keynote speaker yesterday and was supposed to give the introductory talk here. So that puts us a little off our schedule, but I think it's okay. We'll do that topic, but I think it gives us a little more time to focus on. I think we should continue this discussion on coronary artery a little bit more.
Sure, let's do
Because
that.
I actually, we can continue this because this was going in a very positive direction anyway, and then we'll go back into the other topic because Nagabi's talk was so critical to that. And if assuming he joins us, then we'll stop sooner. But actually, I wanted to make a comment on this because I've spent a lot of time looking at this topic of doing calcium scoring, and in LCAP in screening, we actually introduced this idea of doing calcium scores for screening, where we developed our ordinal system. We did that with Dr. Shemesh from Israel back in 2000. I think we first started doing calcium scoring. But what continues to be striking to me, several things. One is that lung cancer screening, especially in the United States, in essence requires that you do some sort of calcium scoring on all your lung cancer screening cases. So even though they're outside the guidelines, many of these patients, for doing a calcium score, we're doing it. We're calcium scoring. Now, we did an ordinal score, which was a simple score where we looked at 4 vessels in the heart, left main, LAD, right, and circumflex, and 0 to 3, none, mild, moderate, severe, and also a score between 0 and 12 total, which we thought was not as good as a true calcium score, but we demonstrated very close correlation. Then it even went to a lesser score than that, where people were just gestalting it, none, mild, moderate, severe overall. And that became good enough. And that was as part of sort of lung rads that became. But the idea is how much does this really matter? We're going to get these scores. What do we do with, do we need better scores than that? Because they correspond pretty well to the major categories in coronary calcium. And we're sort of moving now towards this idea of we don't need to gate. Does it matter if we use thin or thick section? This is that whole section there of standard versus low dose. I mean, how much does it really make a difference at this point to get a better score than none, mild, moderate, severe? And I'm just curious what the panelists think about that.
No, yeah, we did. Can you hear me? Yeah. But yeah, we did a study on this because we did also a publication on this. Of course, yeah, you cannot really when a non-gated scan without any calcium proven on a non-gated lung cancer screening session, it will not prove that there is no calcium. So you cannot exclude calcium. But if you prove it that there are calcium and you can count the different vessels, we made a relation and I think we published this, but I'm not sure. We did the same thing, that we made a complete relation between the number of vessels that contain calcium versus the calcium score. And we found a very, very interesting relationship. So I think there could be a way, but that's a completely different way of working your way forward with the information on a lower end system without ECG triggering, where you find calcium in the coronaries. So yeah, I don't know what the end will be, but I think at the end it will come to a certain indication for a gated examination. So ensure that you can come to a relationship between vessels involved. So if you find, we are also looking to, of course, we know that coronary calcium in the right coronary artery leads substantially in less patients to cardiac infarct than in the LAD. And all that kind of risk stratification that you can do by a vessel calcium score, so to speak, could be an interesting way to work your way further. And then if you find calcium in the LAD on a non-gated scale, but I'm just projecting now for the coming 5 to 10 years, in a non-gated scan, then I think that could lead to an indication for a real gated scan. So you would get a subset out of the lung cancer screening with an indication for a true calcium score. That could be a way out. With the connotation, so a disclaimer that no calcium on a non-gated low-end system, which suffices for lung cancer screening, does not exclude the existing of calcium. So that could be a kind of way that you could use the information on non-gated scans and lung cancer screening. So we are working on this. We also did a publication on this. So we think that it could be useful, and that was based on the Nelson data. So you can also find that.
I've always had this thought, because when I've spoken to cardiologists in particular about technical parameters for doing coronary calcium scoring, they're really dug into the idea that you should only do it with 2.5 or 3 millimeter slice thickness. And we can see small calcifications much better with thinner sections. So I always had this. So I had this dream that maybe, since in lung screening we're doing thinner sections all the time routinely, that at some point maybe we would start readjusting our viewpoint about a 0 calcium score, and that perhaps we would do even better in terms of getting a 0 score with lung screening. That it might be more meaningful.
But we did in all our studies, also in the Rubinska and also in Fernler, thin slice.
Well, we're eagerly awaiting some clue as to what that Rubinska study is showing us, Dr. Utkirk.
I think you don't have to wait longer than 12 months.
How thin were your slices in Rubinska, Dr. Utkirk?
Yeah, we will try to do it. Of course, we can do in conferences a little bit earlier, some information.
How thin were your slices in Rubinska?
Pardon?
How thin were your slices in Rubinska?
1.2, I think.
I think I would agree with you, Dr. Yankelevitz. I think it's thinner slices. Yeah, I'm a cardiologist, but the thinner slice, it makes sense. It's intuitive that the thinner slices would make more sense, because when you say somebody has a 0 CAC, then you're sure that the patient really has a 0 CAC, right? So you definitely increase your specificity for 0 CAC very much with thinner slices. We have a question from Dr. David Maron. Can we go back to the topic of reporting CAC for secondary prevention? We don't know that it is not important to report.
I think you're right. There's not evidence that that it's not meaningful. It probably does predict events. I think it's more just that we don't know what to do with it. If patients have already had an MI, they are kind of indicated for pretty intensive prevention anyway. So like, what's the actionability in a secondary prevention patient? And also, just a lot of the secondary prevention patients are going to have hardware that is like not that easy to distinguish from calcium.
Absolutely. And that goes back to hardware, including stent placements and the rest of them. And Dr. Maron, you said especially for patients not on statins, but that's the point that Dr. Lin is making, which is that if it's for secondary prevention, then they should by definition be on statin therapy anyway. So I don't know if that answers your question or sorts that out for you.
If I could be so bold to come on and respond, there are so many patients who have a diagnosis of coronary disease who do not take statins. And it is possible, and we don't know the answer, and actually we're studying this. It's possible that a patient who has ASCVD and is not on a statin, who sees their CAC, which should be fairly heavy in somebody with coronary disease, might motivate them to follow their doctor's recommendation. For some reason, they hadn't, they had decided not to take a statin because they were afraid that it was going to cause liver disease or dementia or muscle symptoms or other side effects. So that's something that we're studying, and we don't know the answer. And it's possible that just confronting a patient, having them see their own atherosclerosis might motivate them to follow recommendations.
Dr. Maron, I couldn't agree with you more that for primary prevention, I think CAC scoring is particularly motivating for a lot of patients. I use that all the time in my patients in clinic, but you were asking about secondary prevention particularly, which means they've had some sort of cardiovascular event.
Right. I mean, the number of patients, the percent of patients who have had an MI who are not on a statin a year later is shocking. So I'm just raising the question because I think that you or someone else said we shouldn't report it. That's something in somebody with a diagnosis of coronary disease, we shouldn't even put it in the report as an incidental finding. And I'm just questioning that policy.
No, I think that's a good point that, but I think also it would be useful then just to, even when you're, writing the report, right, to say, okay, you're no longer linked to like a CAC DRS, like this is not, don't look at MESA for any kind of scaling, right? In a secondary prevention patient, this, it is a reminder to maximize medical therapy. I think, you saw this in LCAPs also, right? Like most of those patients were indicated for statins. And I think that I can't remember the study, but there were a lot of them who were not.
Yeah, it's worthy of study, and a year from now, hopefully we'll have published on this what our observations are.
Well, I knew, Dr. Maron, that we wouldn't be able to keep you away completely from the coronary calcium session. So I'm glad you were able to join and shed some light on some important topics. I wanted to raise another question, though. And Matthias, this is probably directed more towards you, because all the complexities of measuring lung nodule volumes and things like that. And we even spoke yesterday briefly that, there's sort of a size threshold where volumetrics really starts to not be so meaningful or useful because the extent of error. And I have for many years been sort of half jokingly saying that if you think measuring the volume of a lung nodule is hard, measuring the volume of these little calcifications in coronary for coronary arteries is actually much harder. The proportionate error in those measurements of summing up 2 millimeter little calcified plaques that are partially calcified, different densities, some of them are big, some of them are small. The measurement error, and we're talking about following over time change in calcium score. The measurement error associated with this is going to be enormous. So I think it's a wonderful idea to be able to look at people and track change, and especially in the context of lung screening, where we're going to be screening these people year after year, and we potentially will be looking at their calcium scores. And if we're going to be changing it from something to a real score rather than a non-mild moderate or something like that, this is going to be a very, very challenging area. So I just wanted to know if any of our panelists have any thoughts about this. And I know, Faye, you had to look up the definition of Theragnostics. So this is sort of an example of how useful is this going to be? Is this something we're dreaming about for the near future, or is this
No.
way down the line?
No. We will answer this in the coming months. Yeah, so we have about 2,000 repeat scans under the same conditions. So we can compare the calcium score at baseline and 3 months in 2,000 participants. And then we will come up with the standard deviation error. So we are pretty sure that the calcium score will not change very much in 3 months. So we will give you the answer to your question.
Yeah, I think that lung, in a way that applying calcium scoring to lung calcium CT is it's gonna give you the volume to really answer some of these questions. Maybe it will be a way to develop new evidence.
No, I think it's extremely relevant question. So we can easily answer it. So no problem. We will.
Go ahead.
This is for the Madrid meeting, David.
Yeah, I'm looking forward to it. Okay, Matt, any other questions, or we want to wrap this session up?
Yeah, I just wanted to comment on a couple of things that you had mentioned actually about how we score calcium in lung cancer screening right now, which is basically categorized as mild, moderate, severe, or 0. And one of the I think main issues there that we face is that if we don't take the patient's age into account, mild doesn't always mean mild. In other words, if the patient's 55 years old and we say there's mild calcium, that could be actually really bad for that patient. That could be very bad news. But if they're 79 years old and they have mild calcium, that's good news. So the question is, when you put in a report, or when we put in a report, because that's what we do here in Seattle as well, we say mild, that's not really meaningful, because mild could be bad news for a young patient, but could be great news for an older patient. And that's where the nuances are important.
Now, the most dangerous are calcifications but that's just an expert opinion, so we have no proof there. But from the many patients that we saw so far is between 40 and 50, with one very precise calcification in the left main. Now, those are the patients that will get this major infarct. So then you are at the very onset of major damage in the left main, and this very precise small calcification points to that very place where it's already happening, and those are the patients that are on extreme risk. And contrary to what you said, I was in this cardiac institute in Moscow, the largest with only, I think, 500 only cardiac beds. And they showed me a patient with a calcium score of 10,000 or something, 2 completely occluded coronaries. And I said, okay, what is this? It was a coronary angiography. So the patient died on the table. No, they said. He had some complaints that it was very hard the last time to bicycle uphill, that was not really nice anymore. But he had a collateral perfusion that was incredible. So with 2, that's for me, that was a paradigm shift. 2 closed coronaries, left main and the right coronary, and still just going on. So with extreme high calcium score. So those are the 2 opposites. And I think that the real risk is in this younger patients with moderate calcium, or even just between a little bit lower than 100, and then it's a real indication that something can happen. So if you come over all these infarcts and all over, and that is why I say, okay, really the perfusion of the muscle, that is the key issue, and not the coronaries. So if you have a collateral circulation, for example, you can have a fantastic collateral reverse collaterals from one to another in the posterior descendants, that it takes over completely the other side. It all happens, you can see it, and there is no problem. So it's all about the perfusion of the cardiac muscle. And we should use the calcium score as an indication. It's just an indication from what is happening, but it is not really predicting what. I think it's a risk that is hard to translate to the individual. So where we are looking at those risk stratification in the groups is very correct, I think, but the translation to the individual is more difficult than in lung cancer screening.
So just a couple of comments, Dr. Utkirk. So, you had talked about MRI, talking about perfusion, which you're talking about now. You had talked about MRI perfusion. One issue I see, of course, is the issue of costs and availability of MRI for assessing perfusion all over the world, right? So in major academic...
No, wait a minute. But it's not 50% of the price of this nuclear stuff. But the problem, it's 30% of these nuclear examinations. And that's the key why the cardiologists in the US do not want to shift to MR. It's an economical, financial hurdle. What is really stopping this translation to another modality?
I wouldn't blame it on the cardiologists so much. It might be the nuclear physicians.
And then the other thing I was going to say about nuclear is
they have many private practices driven by cardiologists.
Yeah.
Have their own nuclear system to do that. That's what I learned
and nuclear is also, apart from cost, nuclear is also less cumbersome than MRI is overall. But the other thing I wanted to comment on is in terms of nuclear, more and more, a lot of programs are shifting from SPECT to PET nuclear imaging, which has better sensitivity and better specificity for detection of disease. And in fact, in my institution, we do use
even more expensive.
Okay, so you can make that argument, but I'm just saying that there's a great role for nuclear, because like PET nuclear, you can actually use it to assess myocardial blood flow and microvascular disease. So, and if that's the case, then you can also use it to assess parameters like collaterals, like you were talking about, like bridging collaterals that you can have sometimes when people have major coronary stenosis. So I think PET scan is going to be most institutions that are now dealing with SPECT in future are going to move more and more towards PET scan imaging. But I think cardiac MRI, I think, is part of the future of cardiology, as I'm sure you know. But I do hope in future that cardiac MRI, overall MRI machines become less cumbersome to use and more affordable overall.
Now the industry is aiming for PET CT, yeah? So then you have the coronary calcium, you have
absolutely,
and you have the perfusion of the PET.
Right, absolutely.
And that is, of course,
you have all the information that you need at your fingertips.
Yeah, but it's very expensive, and the perfusion is not as good as MR can provide.
Okay,
the PET CT folks would disagree with that.
I think
I understand that.
I think we'll move on to the next session, which is reporting non-coronary cardiac findings on lung cancer screening. This will be sort of an abbreviated session, but I think that's okay because I think we'll even give ourselves a little extra time for the third session this way. So we'll make this a very abbreviated session on the reporting non-coronary cardiac findings in lung screening, and save a little time from this session as well to focus on the designing of a cardiac controlled observational study, because I think that's going to be particularly interesting. This session was going to be led off by a talk by Dr. Nagavi, but on the conference yesterday already heard, I think, much of what he would have spoken about today. And he had a lot of really exciting data that he showed about the kind of information we can collect from non-gated low-dose scans, where we can look at chamber sizes. And he pointed out all of the various things that we can now make predictions on, notably enlarged left atrium predicting AFib for the future. I mean, and he had some really pretty spectacular data on this, that it performed much better than literally any potential other scoring mechanisms to predict AFib. He also was able to demonstrate that looking at left ventricle size and right ventricle size, he has a lot of information now that's being submitted now for publication that predicts heart failure. So this is the kind of thing that I thought was particularly of interest. So we wanted to have this session really focus on what are the non-coronary calcium features that we think are important. And I'll just give you an example, and then I'll throw it open to several of the panelists. You know, growing up, when I started reading chest X-rays, the first thing I report on a chest X-ray is heart size is on any chest X-ray, a portable chest X-ray, a routine heart size is normal, heart size is enlarged, this whatever. When I read a CT scan, I don't report the heart size. I don't even attempt to say anything about it. I mean, it's quite a step. So just something as simple as that is already. I mean, sure, if I see a big heart, you know, I'll make a comment, or I see a chamber that's really off, I'll say something. But otherwise, I don't say anything. So that's sort of where it starts. So I'm not going to spend a lot of time on my own thoughts about this, but just throw it open to the panelists. What things do we think are worth measuring at this point? You know, you see there, some of them are kind of listed, but including also, I think we can also include here, beyond coronary calcium, what other things might be useful even around the coronaries? Are we going to start talking about, you know, the fat around the coronary arteries? Is that something we should be starting to think about routinely reporting, or epicardial fat? Sure, if we see a big aortic aneurysm, we'll say. So anyway, I want to throw it open to the panelists to just say what things should we be routinely reporting on these, especially in the context of lung screening. So, David, do you want to start?
Sure, thank you. I think that aortic valve calcification could be very important. There are scores above which significant aortic stenosis is likely in Agatston units. And so that's one thing that could be a sign for early intervention, for further evaluation. It may stimulate an echo to determine if the degree of aortic stenosis is clinically significant.
Yeah, just as a quick aside, we actually published on that in the context of screening, where we did aortic valve calcium scores using Agatston's, sort of an Agatston scoring system. And it turned out there was a very high correlation with echocardiography. That's one, and in fact, we do routinely report that on our screening cases. So I agree that's an important one. Anybody, do you want anything else you want to comment on, or?
No, I just thought I'd start off by mentioning that and hear what others have to say.
Yeah, I completely agree with the importance of aortic valve calcification, the implications for disease detection and treatment. One of the issues that we encounter in clinical practice is that aortic valve calcification generally is a little bit labor intensive for even our 3D lab to segment out and measure. It takes them between 10 minutes to 30 minutes to trace it out. A lot of the automated software is not able to distinguish between valve calcification versus aortic wall, aortic root calcification. And so the human is usually required to accurately trace out the region of interest. That being said, since we don't encounter this very frequently during lung cancer screening CT, that kind of offsets a lot of the potential labor issues involved with finding this this marker. But on the other hand, we have to be prepared essentially to invest that labor or technical expertise when we do encounter the lesion.
Yeah, I think that that's one that I consider a very obvious one that we should be reporting, and especially because there's something that can be done about it. The majority of people with aortic valve calcification, even severe, don't have any idea that they have a problem. That's another one of those topics where, and we report it, and actually we have to see how many really even do anything about it. So that's one. Matthias, do you have any thoughts on this topic? And I'll just say, you guys have published on aorta calcifications as well, aortic calcium scores, and should we be reporting that routinely in what we're doing? They have different prediction meanings than coronary calcification.
No, we had a 2 years discussion with our health council exactly on this issue, what should be reported and not reported. So that is here already completely politicized. So there are so many calcifications in our foreign lung study from valves, also the mitral valve, of course, and the aortic valve. We are not allowed to report it. What we are allowed to report, and that's what we do, is the size of the aorta. So if there is an enlarged, so in aortic insufficiency, you will have sizes over the 5. We use 50 millimeters. Others use 45, but it depends a little bit on the age. There is a very nice old publication on the relation between age and size of the aorta. So it really gives you the table of the normal value and size of the aorta per age group. And I think that is very valuable to use. And if it's over that size, so over that range, we report it.
You said something just now that strikes me that I want to ask more. You say you're not allowed to report it. So if you see somebody with a lot of aortic calcifications, and you know that has some meaning, especially in terms of stroke prediction and vascular disease, you're not allowed to put that in the report. Is that?
No.
Wow. That's something. And what happens if you do? Do you go to jail? Do you?
No, we go back to the discussion with the health council again.
Worse. So worse than going to jail.
Yeah, the minister will say you're violating the protocol, so we stop the allowance.
What's the rationale for that? Is because they find that the results are meaningless or not enough evidence?
No, in the Netherlands, that's really something. Huh? We offer everything for the whole population, so there is no personal pay for anything, and we have here. I think we. In the execution, we are the most socialistic country in the whole world, so everything is for everyone. And then what is getting important is, and that is what they are fearing for, that we get a complete a medicalization, I should say, from of the population. What is already happening, I think. And this is one of those aspects. So then we will get a full-fledged service for every calcification in the valves, and patients will demand further workup for any calcification in the valve, that kind of stuff. because the report is open for the patient as it is or the participant as it is in the US, I think. So they will read that there is a calcium in the valves, and they will just demand, and they are all insured by the same. So there is no personal, you have you're not hampered to do anything more. You have no costs. So you find, okay, I do the workup, the full workup, and no one can really stop this. So that is the reason why everything in the Netherlands. So if we do this, what will the result be? An over medicalization of everyone that has a little bit calcium in a valve somewhere, because it gives no cost. There is no influence. There is no the insurance companies just have to pay. It's all obligatory. So you start a complete automated workup for everyone with a little bit calcium in the valves. So that is the reason.
Well, but just to stay on this topic a little bit longer, aortic valve is one of the few things that you can really do something meaningful in this population. TAVRs are wonderful procedures, very effective.
I think the stenosis is, of course, only relevant for the younger people. If you survive the stenosis up to your 70s, then it will also become insufficient. And then you will get, that is the reasoning why we may report on the aorta size. Then with the insufficiency, the size of the aorta will develop to a larger size. And if it's going over the normal size with all the standard deviations, then it becomes probably relevant to treat the valve.
David, do you want to comment on that?
Yeah, that does not conform with the way we're practicing in the United States, and there's pretty good evidence that earlier intervention for severe aortic stenosis has important, it reduces important clinical events. So
but which age groups? That's the point here.
Yeah, actually in all age groups, but particularly it's the older age group with degenerative calcific aortic stenosis that we're talking about. It's going to be more common in older age, and I can't go further because this is not my area of expertise, but I am studying right now for the maintenance of certification for valvular heart disease, and severe aortic stenosis and the presence of our accessibility to TAVR is something that we use.
Well, I'll just tell you, my 95-year-old mother just had a TAVR a little less than a year ago, and she went from as critical a stenosis as you can get, according to her cardiologist, symptomatic, et cetera, to being totally asymptomatic, basically a year later. So on that very anecdotal note, I'm a big fan of looking for critical or severe aortic stenosis.
This is a real complete cultural opposite view.
No, understood. Let's talk.
Here we would say above 90, we do not do anything anymore.
Well, I understand.
Yeah.
Let's talk about a couple of the other areas here. What about something like just reporting heart size? Think that's going to be meaningful?
I think your introduction was great. It's eye-opener. It's an eye-opener.
Yeah.
We were trained like this. It had to be in the report of every chest X-ray. It's an eye-opener. That is fantastic. It's a fantastic remark. So you gave with this remark the answer.
Yeah.
Well, one of the issues with chest CTs, like lung cancer screening CT, is that we don't know when the images are obtained during systole or diastole, which means the left atrium, for example, could be anywhere from end systole to end diastole. So it could be small or big, even in a normal person. And ultimately, I think one of the reasons why the work of Dr. Nagavi makes sense is because it's looking at the largest of the large atria. In other words, if you look at 100 patients, some of which are in systole, some of which are in diastole, in terms of image acquisition, if you look at the biggest of the big atria, then you might be able to say, oh, this person's likely to have AFib. It's possible that you might have missed some of them that are in systole when you image them, but you will be able to capture some of them. And so it does make sense that if you filter
absolutely.
out all your findings.
It's very nice. It's very
Matt,
nice.
what about just heart size, period? Forget even the individual chamber size.
Yeah,
You know,
but
is it bigger than half the diameter of the chest?
Right.
Yeah.
That's useful too. Absolutely. Right. I think when we do that in practice, we usually report the heart size as upper normal or enlarged. But I think what was great about Dr. Nagavi's approach is that he was able to actually quantify it and then say there's a 40% chance of heart failure given the size of this heart, which I think is much more meaningful for the provider, as opposed to saying, you know, borderline enlarged, which I do a lot, because I'm not sure if it's really abnormal or just upper limits of normal.
Okay. The other thing that we routinely report on our scans is pulmonary artery size and aortic root size and the comparison, and we list that on everybody, and we have found that there's a lot of enlarged pulmonary arteries out there that people don't know about. You know, a lot of times it's borderline or it's a little bit enlarged, but it's substantial. It's substantial. Now, whether or not anybody's acting on this or what to do about it, we haven't really looked at, but it is surprising how often that's present. What do you think about that? Do you think it's something, Matthias, I'm sure you're not routinely reporting that. You're not reporting aortic valve calcification. I doubt you're reporting sizes of pulmonary arteries. But,
no, but of course, study-wise, we can work on this. So there's a difference between reporting and studying and researching and publication. So we still can do that, of course. And then if we can prove that there is relevancy, then it has to go through the implementation phase, what the costs are, the harms versus the benefits, and then it can come into the report. But from a studying point, we are studying all this, and we are also working exactly at the same things that Nagavi showed. And I think this is a fantastic way to go. But the remark of Stephen Lamb yesterday, that you should have the information about a phase in which the heart has been the data has been acquired, remains important, and probably there are ways to get that done. Now the difference between a chest X-ray is the chest X-ray has an extremely short acquisition time. So that is even 10 times or even more shorter than that of the CT. So you get very precise measures. On the one hand, on the other hand, you can also evaluate immediately how good the inspiration was. So David will also remember that we had to start the chest X-ray report with the position of the diaphragms. So we would say good inspiration. That was just descriptive. And if you said it was a good inspiration, then all kinds of evaluations would follow. But if the inspiration was not good, then you could not really measure the size of the heart in comparison to the diameter of the chest wall. And yeah, that reflects also the problems that we will have, of course, in the measurements of those same structures with routine chest CT. So that is just a remark. On the other hand, I think if you measure the muscle itself, which is very, very relevant and very nice, so the muscle mass, the cardiac muscle mass, that will be not so. So there are studies, very nice cardiac studies, that show that the total volume of the muscle mass is not changing that much in systole and in diastole. And so the shape is completely different, but the sum of the muscle mass remains the same. And I think that is a very, very interesting thing to know. So it is probably also independent from the position of the diaphragms. So that could be a very objective measure for all kinds of diseases. We know it. So that the muscle mass itself, the hypertrophy, the results of infarcts, at the end, the very if you have a dilated cardiac muscle, then it will be very small. So the muscle mass itself will tell you already a lot about will be predictive for many, many cardiac diseases. That's what I think. So the first thing that we'll be interested to do on the lung cancer screening is to come with a muscle mass figure.
Let me just go finish your thought, and then I have a question, a comment that I'll make.
On the other hand, there will be extreme pathology, of course, as you mentioned. So it could be interesting also to measure the left atrium, because it's quite simple to measure it, and then related, of course, to AFib and also to CVAs. And if there is a relation, then to implement it. I think that's also a very interesting way for research to go in that direction. And it could also all be just implemented in AI, so that you get all those figures automatically in one scan.
Yeah. My last sort of question for this session is, if you think about yesterday's talk about the chamber size and muscle mass, and imagine that we'll be doing things, and I think the relatively near future, potentially saying things like, this person has certain % chance of developing AFib in the next 5 years, or chance of going into heart failure in the next 5 years, that kind of thing. This is a lot of information now to be giving out. And there's been resistance, and we'll talk more about this. You described, for example, in your country, Matthias, that you're not even allowed to report some of these things. Imagine, what the clinicians are going to be doing when we start telling them, your patient has a potential for AFib, heart failure. I don't know if Toshi's on the available to comment on that as well, or Faye. But David, maybe you could start. Do you think this would be overloading people? They're not even dealing with the coronary calcium scores at this point. Can you imagine we start telling them all these other things?
That certainly could be a challenge and overwhelming for the primary care physician who is already overloaded. So there'll need to be very clear guidance on what to do with the information, linking to guidelines. There's a fine line between being too prescriptive and just providing information and hoping that it'll get translated into appropriate clinical decision making.
Yeah, I would agree. I think framing is really important. And I think also that issue that Dr. Utkirk raised about downstream testing, is going to be something that we're going to have to worry about, because, it hasn't happened that frequently, because I guess there's underutilization of lung CT, but I certainly have seen a couple of calcium scores, which were ordered as a response to a mild or moderate amount of calcification, reported on the chest CT, where because people don't know how to anchor or frame that clinically, then they get a calcium score so that they can turn it into a number that they know how to interpret. So, to Matt's point, there isn't like a age-adjusted nomogram for mild, moderate, severe calcification the way there is for an actual score. And so, in a way, like information that's presented without framing turns into noise.
I do think that in the near future that there will be scores available that are provided by AI vendors who have algorithms to provide scores that are FDA cleared algorithms.
Tochi, you'll have the last word.
Sorry, yeah, I think that in terms of AFib and the rest of them, I think, in terms of predicting risk, what's going to happen is that, just like Dr. Maron was saying, that there's going to be scores, just like you have coronary calcium score. But what that's going to end up doing, just like it's doing now, is that it's just going to end up generating more referrals to cardiology. Because that's what most primary care doctors do. They see a coronary score of 200, or they say, radiologist reads a lung cancer screening CT, and they say, oh, there's moderate amount of calcification, and that automatically generates a referral to cardiology. And I think that is going to be the mainstay of what's going to happen in future, unless we figure out a way, like Dr. Lind was suggesting, unless we figure out a way to put the information that we're giving clinicians in, figure out a way to put it in such a way that it's standardized, or like in a nomogram or something like that, to make them say, okay, here's how I can think about this, here's how I can think through this, and then what will be the next best steps. That's one of the things that, I think a lot of the cardiovascular imaging advocating is to say, what is the immediate next step for this particular patient? If there's a way that you could give that sort of information to the clinician, then that's useful. More testing, or this risk means that you should start the patient on a statin therapy, or that you should refer to cardiology, or whatever it is that the next best step would be. If there's a way that we could algorithmize the whole picture and provide that sort of information to clinicians, then I think it'll prevent further downstream unnecessary tests or unnecessary referrals or unnecessary stress related to the patient and the clinician.
I think we're going to... Go ahead, Matt.
Go ahead. Oh, I was just going to add one last thing to that point that both Tochi and Faye actually made, which is really important, which radiologists can actually fix this, but for some reason, nobody wants to fix this because it takes time. So in our practice anyway, in Seattle, we get a lot of patients where on chest CT or lung cancer screening CT, we'll say the aorta is dilated because it measures 4.3 centimeter. Well, it turns out 4.3 centimeter might actually be normal if the patient were large, if they were male, if they were older. But the problem is we don't bother to collect their BSA. Even if it's in the patient chart, we don't even look at it because we have no time. We don't collect the patient height and weight. But if we did that, we can actually offload that work from the care provider, so that when we tell them that the aorta is dilated, they can believe that it's really dilated, as opposed to a false positive because the patient happens to be a large patient or an elderly patient. So those are some of the things that we can do so that when we give information to the provider, they know that it's actionable, as opposed to another red herring or false positive that is going to waste their time or waste on downstream imaging.
I think that's really a very important potential role for AI, is to scrape the EHR for the framing, and not just the image for the result.
Absolutely.
Now
Matthias, last word.
Yeah, we are doing this. So this awful Dutch Health Council allows us to report all calcium scores over the 400 as actionable. So we will report it when it's over the 400 to the GP to take further action.
Okay. Well, I thank everybody for participating.
Vice versa. What you mentioned before, we would not report anything if it's lower than 400. So no calcium scores. Only, so that's exactly what you mentioned. So we are not allowed to report when it's lower than 400. We do no reporting. Only when it's over the 400, we report it.
Interesting.
Dr. Utkirk, I think there's a lot to be said for that, though, especially when we know that, just like Faye had presented, that in the intermediate risk patients, that there is some role for primary prevention strategies, right? So, yeah, I think 400 is a bit high for cutoffs for reporting.
Okay.
Okay.
Let's close it now. We have one more session where we're actually right on time now. The next session was titled Designing a Medicare Cardiac Controlled Observational Study. And this topic was sort of stimulated by the idea that, especially with AI, there's really been an explosion of new software to evaluate all of these different things, and not just cardiac, but other lung findings. And how do we get approvals for this? I think in the U.S., our main thought for getting approval is getting it approved by Medicare. How do we get them to pay for it? Because as we're hearing, people want, are building software, and everybody's got an approach to why their software is so important and why we have to do it. And companies are going to Medicare and trying to lobby them to get this approved. And one of the big topics that we had been thinking about was, things like coverage with evidence development. How do we get Medicare to approve some of these with a view towards coverage with? But yesterday, the breakout session was very enlightening, because it kind of started talking about this whole topic. Really became that was in essence what we wound up talking about to a great extent yesterday. How do we get coverage for this? Because it's become pretty apparent that radiologists don't want to start reporting any of these additional findings because they're not getting paid for doing it. So we started thinking about how do we get approval to be able to report some of these additional findings. Yesterday, one of the topics was reporting lung fibrosis or interstitial disease. That was what sort of stimulated the talk and moving into that direction. So we want to start talking about what type of evidence is sort of necessary to get the insurers to pay for it. And I think in the United States, it's to get the insurers to pay for it. In the Netherlands, it might be how to get the advisory boards not to cut off funding for your whatever it is you're doing. But it's sort of the same idea. How do we collect the necessary evidence? So in this session, we have are adding Bruce Pyenson, Senior Actuary for Melaman, to talk a little bit about this topic. We have David Maron. I don't know if Mort has joined us yet, but I know he was interested in this, and the others here can join. And I'm hoping that Richard Frank is available, because he was main participant. Is Richard joined? No. Well, maybe we could put Anita on as well, because she has some things she can add to this topic as well. She had some surprising information. But to start this off, we have, I'd like to have Dr. Maron. I know he's prepared a few slides on a very closely associated topic that bears on this, that I'm hoping. And for those who don't know, Dr. Maron is Chief of Preventive Cardiology at Stanford University and has been involved in some of the really major clinical trials related to ischemia, et cetera. So, David, why don't you take it away?
Thank you. I didn't know I would be presenting the slides. I'm hoping that you have the slides up to show.
Sorry, yes. Do we have Dr. Maron's slides? We do, so that's available.
Oh, thank you. Okay, well, many of the audience may be familiar with this information. In an observational study done at Walter Reed, the patients, or I should say, the military people enrolled who had no history of atherosclerotic cardiovascular disease at baseline were simply observed. They all had coronary calcium scores calculated. There were about 13,000, mostly men, and the analysis looked at what was the incidence of death, MI, stroke among people who were on statins and not on statins according to their coronary calcium score. And as you can see in blue, this is the group that were not on statins, and in red, those who were on statins. You can see a very obvious separation of these curves within a few years of follow-up. And so I didn't show what happened to the people with scores less than 100, but here you can see what happened in people with a score of 100 to 400 and greater than 400. Next slide, please. And I'll point out that the American College of Cardiology has an expert consensus decision pathway that recommends that when people have a calcium score of 100 or greater than the 75th percentile, that they be started on moderate to high intensity statin therapy, and that the therapy be intensified if an LDL less than 70 has not been achieved. And for people with a score greater than 1,000, started on high-intensity statin therapy, again with an LDL goal less than 70. Next slide, please. We are planning a trial. We're applying to PCORnet, to PCORI with sites in the PCORnet system to determine whether notifying patients and their clinicians about the presence of incidental coronary calcium greater than or equal to 100 as determined by an AI algorithm on a lung cancer screening low-dose CT, whether notification reduces atherosclerotic cardiovascular events in patients who are not on lipid-lowering therapy and do not carry a diagnosis of atherosclerotic cardiovascular disease compared with usual care. I don't know if I have one last slide. Just the design. We have a waiver of consent approved by the Stanford Institutional Review Board. We will take people who have already had a low-dose CT. So we're going to go looking back 5 years as a way to rapidly accrue a cohort for the trial. People who, according to the electronic health record, have no ASCVD, not on a statin, have a calcium score greater than 100 as determined by the deep learning algorithm, and then randomized to be notified along with their clinician. And the notifications include an image of the best representation of their coronary calcium compared with no notification, and the primary endpoint, cardiovascular death, non-fatal MI, non-fatal stroke. Next slide, if there is one. There is not. And we did some preliminary work at Stanford looking at this, at a group of patients who had undergone non-gated chest CT for any reason and had coronary calcium greater than 0, so any coronary calcium, to look at what was the initiation of statins among the group that was notified compared with not notified. We published our results in Circulation earlier this year and found that in the notification group, and again, these were statin-naive patients, that the prescription of statins was 51% in the group that was notified compared with 7% in the group that was not notified, again, over a 6-month period. at 12 months, we haven't published these results yet, the persistence of statin prescription is 50%, which is kind of amazing to me. So that's for framing, and I'm done with that presentation. Thank you.
Thank you, David. Again, one of the thoughts for this session was with all of this software being developed and all of our abilities to do calcium scoring, prediction, how do we go about getting reimbursed for this? And one of the stimulants for this also is, for example, things like osteoporosis scoring on these low dose scans. Now, that's something that can be done. It's recommended. There's, if you're a certain age, you should be getting DEXA scans, and now it's been shown to be substantially equivalent. For example, that the CT findings of osteoporosis are now considered equivalent to a DEXA scan, and yet you can't get reimbursed for doing it. So you can't just bill for it. It has to be separately ordered. So even though we can do it on these patients in low dose, we can't get that paid for. And there are many examples of this. Obviously, you can't get paid by Medicare even for doing a calcium score on a patient. They just won't pay for it. So the idea of what type of evidence is needed to get things approved for payment became a real important topic. And one of the thoughts was, to convince Medicare to do what's called coverage with evidence determination. And if that was and that was sort of the path that we were kind of going down here with, was what kind of a trial we might design, which is sort of kind of what you're doing now, what you sort of described, although you're going to be doing with PCORNet. We were thinking about how to do this with Medicare. And I had a conversation with Bruce Pyenson about this. And Bruce is in a particularly advantageous position because he's been an advisor to Medicare. And I'd like for him to give us some thoughts about whether he thinks that's the best approach for getting some of these tests, and a variety of different tests that might be approved, whether it's enlarged left atria, et cetera. What, the approach you're taking, what could we do to get Medicare to approve giving reimbursement for some of these things? You're on mute, Bruce.
Thank you, David. Just for background, I had been a commissioner on the Medicare Payment Advisory Commission, which actually advises the U.S. Congress and not the Medicare program on Medicare policy. Let me start out by saying, on a big picture basis, the pathological finances of U.S. healthcare are being exhibited here in a couple of ways. One is that the majority of physicians are not paid by payers. The majority of physicians in the U.S. are employers. So when we're talking about our employees, so we're really talking about payments to the companies that employ physicians. If we were talking about payments to physicians, we probably have to talk about a minimum wage for physicians or something like that. So the fee schedules are for physicians at this point are mostly going to the entities, perhaps hospital-owned or perhaps owned by private equity or group entities, and not physicians themselves. Now, that said, I think the Medicare program, with respect to the much of its activity, runs on a budget basis. So if more is paid for some kinds of services, less is paid for others. And I think that's fair. and especially when it comes to newer technology, that newer technology should devalue the older technology, as it does with so many other areas of the economy. I would say that Medicare is a huge information engine where the information they have is not electronic medical records, it's enrollment data, it's claims data, it's encounter data, it's the elements of services provided, diagnosis codes assigned, outcomes, eligibility, mortality. And those are the, that's the circulatory system, and the pulse of the Medicare program uses that kind of information. And I think with respect to a lot of the topics being discussed today, that data is retrospective and available, and it's immediately available, and it's available on tens of millions of lives. So that's a very credible source for Medicare. Medicare staff itself would have difficulty reproducing information in clinical trials, but it would have no problem at all reproducing and altering and investigating its own databases on the outcomes that are many of the topics we've discussed today and yesterday are relevant to. So, for example, although lung cancer screening is underutilized dramatically in the Medicare population and then all populations in the U.S. There are nevertheless tens of thousands of people who get lung screens in Medicare every year, and we can follow those people, and we can look for changes in what prescription drugs they are on, or what they've been diagnosed with the years before the scan and the years after the scan, because the overlap in conditions and the uptake of services and the high-level outcomes, meaning hard events or mortality, those are all accessible. And I think it's not the complete answer, but I see a real shortage in that kind of analytics. And I think that would really be respected by the analytics-oriented people, policy people in the Medicare program. But to get back to my initial point, it's hard for me to look kindly on calls for more spending on healthcare in the U.S. when we're easily spending double what other countries spend, and other countries have better outcomes. So I think a lot of the calls for reimbursement are probably driven by the corporate entities or others that I'm not very sympathetic to. But, David, did I answer your question?
Yes, to me it was very eye-opening when you said that Medicare kind of respects or takes very seriously an analysis of their own data, and that you can get at kind of hard outcomes through interrogating Medicare data. So, for example, you could probably find out if a person had a collapsed vertebrae just by interrogating Medicare results. You could find out if a person had an MI, if they had, so we could look back, for example, at our screening data and see who had very high calcium scores, who didn't, who wasn't put on statins. You could potentially be doing all that kind of research through interrogation of the Medicare database in a sort of a retrospective way. Because my thoughts initially were, we better design this prospective study and get Medicare to kind of pay for it. And what you're saying is maybe not. Maybe there's a much better way that might even be more convincing to Medicare. And I really am very attracted to that approach. I'm going to let David in a moment comment on sort of getting at sort of the same thing and really looking at an intervention where he's randomizing. But you're on mute, Bruce.
I'm not saying there's, this is a substitute for randomized controlled trials.
I'm on mute. David, why don't you comment on that?
Well, there is a lot to unpack there. With regard to getting CMS coverage for coronary calcium scanning, that's actually the driving force. I've been on this quest now for several years because as a clinician, I order a lot of coronary calcium scans, and it upsets me that insurance doesn't pay for it. And so I set out to try to design a clinical trial to provide the evidence. I mean, the reason CMS doesn't cover coronary calcium scanning is because there's never been a clinical trial demonstrating that screening improves prognosis. And the reason there's never been a clinical trial is it costs too much to do a primary prevention trial. Very smart people have put proposals in front of NIH and they've been denied because they cost too much. And so the idea came to us because we learned in the preventive cardiology clinic that before we order a CAC scan, we should look in the patient's file to see if they've had a CT scan of the chest for other reasons, and we can spare them the cost and the exposure to radiation. And this led to the idea that we could form a huge cohort of patients who have already had CT scans performed, and thereby save a lot of time and money by having artificial intelligence read those scans that are in archives in PACC systems, and therefore identify people who have a calcium score above X and do a randomized controlled trial. So the motivation was to try to get CMS to cover it if we could demonstrate that knowing one's calcium score can improve prognosis. We ultimately chose patients who have undergone lung cancer screening because they're stable, they have a high risk for coronary disease, they are prevention oriented because they're undergoing that test and their physician has referred them for lung cancer screening. But ultimately, this will not be the definitive evidence because it's not taking a general population and screening them to prove that that reduces risk. But it'll be hopefully a step in the right direction, and hopefully it will lead to coverage for dual screening, not just for lung cancer, but also for coronary calcium.
Thank you, David. I wanted to follow up. I'm hoping for results to have more of an impact than your soft pedaling a little bit how much of an impact it might have. I'm optimistic your trial will do actually have a great impact, and hopefully we'll be able to really demonstrate that. Bruce, you said something else that I think is really important, and this came up in the conversation in the breakout group yesterday. Your concern about the amount of money being spent, and that it came up yesterday that maybe, if we're doing all of these additional tests, maybe those who are able to provide this additional information get reimbursed more, and those who aren't get reimbursed less. And Richard Frank even talked about maybe like a tobacco-related panel of additional diagnostics that could be done, and those that are doing it, get reimbursed screening, lung cancer screening plus X, and those who aren't doing it, minus X, something like that. So your cost stays neutral. Are there examples of that? And you're on mute again, Bruce. Things are.
Can you hear me through the microphone, through your headset?
Yes.
Yes. Figured if I shouted loud enough, maybe I could overcome the mute. So CMS loves bundles, and so I think Richard's suggestion of a tobacco-related bundle will appeal to them. The DRG system, which dates back to the 1980s and 90s, is an example of that, as well as more recently the program for joint bundles or other kinds of inpatient bundles where the professional component, the facility component, the post-acute care components are all packaged under one price. So I think that fits well with the thinking of CMS. Its OPPS program for outpatient services is similar. I think there's other approaches. A lot of the conversation in this workshop has been on the quality of images, and part of the standards for meeting quality certifications could involve the kind of reporting that comes out from for lung screening, for example, and certainly that's seen in other places. But I'd like to point out, that CMS doesn't pay for services in healthcare that are provided, right? CMS does not explicitly reimburse for any nursing services in hospitals. Those are all packaged within the DRG payment. So the vital, patient care services that happen every minute of every day, CMS does not have a fee schedule for those kinds of services, right? And that's and there's some people that looking at the current nursing shortage that attribute that reimbursement policy, connect the two of those. But the idea that that there has to be an explicit extra payment for something, I think is if you start from that standpoint, that's a barrier. And I understand why that's there. The expectations of financial return of investors in healthcare technology are much, much higher than they used to be. And that's the sort of market for investment. But I don't think that's the right place to start. I think I answered a different question than you
Yeah.
asked, David.
That's okay. I have a few other thoughts that, and then I'll turn it over to some of the other panelists. Well, maybe we'll turn it over now. Matthias, if you're available, getting things sort of approved to even being reported on the scan, let alone reimbursed. What level of evidence do you need in Netherlands, or for that matter, other countries in Europe, before you're allowed to even start reporting things? And how do you go about getting that evidence? Is it only through the trials that you're kind of doing right now, or are there other mechanisms that you use to get the kind of evidence that allows you to even put some of these things in the report? Is Matthias available? I guess not. Okay. Let me then make a slightly different comment. It was brought up yesterday. Jim had pointed out, and I've heard this directly from Ella, for example, that many of these softwares are just not going to be used by radiologists. They're not going to be reporting anything because it's extra work, and they don't want to do it because they're not being reimbursed for it. And you know, it takes time, et cetera. But then it came out that, but you know, if you start identifying people that are at high risk, you start bringing them into the hospital environment, and then they become sort of profitable for the hospital. You know, they start getting patients with early diagnosis of interstitial lung disease or potential heart disease, that if we're reporting this, that the hospital is going to start making money, but the radiologists themselves are not. And I wonder if we have any thoughts about that concept, that, you know, is that a fair way of thinking about things?
Are there, I don't know if, I don't want to provoke a fight, but when you compare the average income of radiologists to cardiologists or primary care, you know, that maybe argues that cardiologists, non-interventionists should be paid more and radiologists should be paid less. You know, but anyway, I think I go back to the point of, I'm not sure how many radiologists actually get paid as opposed to are employees of a entity, of a corporation, of some other business. So I think the era of the Norman Rockwell painting of what a doctor is shouldn't guide our view of payment policy. For the most part, we're paying companies. We're not paying doctors.
Oh, sorry. I was just going to ask if any of the other people on the panel wanted to comment on that. Otherwise, do we have any other? I was going to bring up one other point that I thought was really interesting yesterday. And Richard Frank was talking that they have now started. He's involved very much with the reimbursement, and he's advising. He's on Medicare panels for how to get these CPT codes and reimbursement for additional software that's being evaluated. And he brought up this whole topic now that they are introducing these T codes, which are sort of tracking codes. So if you do it, you can put a CPT code on what you've done, and you're not being reimbursed, but it's now allowing Medicare to specifically sort of track these new softwares, which, you know, is a big step. And I'm sure that a lot of companies will be applying for that. But then I found out something that I was quite surprised, and I wanted Anita to comment on these T codes. because she told me something yesterday that I found quite astounding. So, Anita, can you comment on the idea of getting reimbursed for T codes now and what some companies are doing? I thought this was really interesting.
Well, it was curious. I was curious to learn a little bit more from Richard Frank, so it would be great to get some follow-up discussion and feedback from him. Of course, he participates with the AMA CPT, and so with that, he was sharing out a little summary, a summary slide with some AI-specific codes that would be Category 3 for tracking purposes as emerging technology. Within that, though, these would be essentially brand new codes for calendar year 2024. And I'm familiar with existing codes that are currently payable under the Hospital Outpatient Payment Prospective System, HOPS, for 2 T codes, and I don't have them off the top of my head, but those are being currently used for a number of AI products. I believe the descriptor for those Category 3 codes, which are also T codes, are I think it's like tissue optimization, CT optimization. And so I understand that there are products like Optone that this can be utilized for, and the reimbursement amount under HOPS is pretty considerable. I think it's getting paid this year around $600 or $700, and next year in the Medicare in the Hospital Outpatient Prospective Payment System schedule for calendar year 24, it's also going to be payable, I believe, under the same APC rate at around $600. So I'm curious to learn more about the differences between these Category 3 codes that are in development and are anticipated for next year for AI versus the current codes that exist.
To me, what you just described is like an explosion. I just find it amazing. The product that you're talking about is something that looks at a lung nodule and through AI gives you some prediction of benign or malignant. That's the Optellum product. And I'm not familiar enough with it to know how good it is or not, but there are other products out there that do something similar and more are on the way. So what you're saying, though, is that product by itself will reimburse 3 or 4 times as much as the lung cancer screening examination, and is being paid for by Medicare now. So if we want to talk about resource utilization, I just don't know what to say. It's just extraordinary that something like that, which and the evidence for its usefulness, I mean, is pretty limited. I mean, they did their study, they got it FDA approved, which is not the highest hurdle. They have a handful of publications on it, but the amount of evidence for the value of that is really limited. And to understand now that it's being paid with a T code at $600 per case, I just don't know what to say. Here we're struggling to get coronary calcium scoring paid for, or things like of osteoporosis, where it's all, we can't get that paid for basically without jumping through hoops. So to me, this is just an extraordinary, and it just sort of shows you that companies have, strategies, and they hire very clever lawyers or business people that figure out how to get this paid for. I don't know what to say about it beyond that. I heard this yesterday, and I really couldn't believe it. I don't know, Bruce, David, anybody want to say anything about that? Are they as struck by this as I am?
I'll defer to Bruce.
Bruce, you're the manager, you're the advisor to Medicare and to our government about saving dollars.
I don't understand, and haven't looked into that issue. there are certainly anomalies in the way that the Medicare fee schedules are established. From Medicare's standpoint, it eventually will balance out, and it'll be offset by reductions in fees elsewhere or adjustments to fees. So, but that's part of their mindset of meeting their budget and creating a stable program. But I don't have insight into that.
I'm already hearing rumors that Medicare is about to start paying for blood tests to start triaging patients for lung screening or not. Again, on very limited evidence. These are the kind of situations we deal with, I guess. You're on mute again, Bruce.
There may be acts of Congress.
I'm starting to worry about you, Bruce.
So someone keeps muting me. There may be acts of Congress that require Medicare to pay for things, and that's, you know, that's the political process, and Medicare is subject to laws that are passed by Congress. So, Anita, you were going to add something.
I was just, I noticed Jim had his hand raised. Did you have a question?
You're on mute, Jim.
Mute. Thank you. Okay, David, I appreciate your wonderment about this observation, but if we're going to actually have sustainable development in this space, I think we have to look towards not some back door, but we have to be forthright in coming to parties that are aligned with our interests. Now, Bruce, you spent a lot of time, you just told us about what not to do. You spent a lot of time telling us previous years that insurers and in particular regions, you know, people that make decisions about these things, radiology managers and stuff like that, potentially would ally with us if we wanted to look at particularly compelling new applications, and we could do a pilot in some discrete business entity. And we come back to that at some point, perhaps. But the second thing is, I think we're overlooking the breadcrumb that Dr. Maron dropped in front of us. And that is that PCORI's job is to do this stuff. And PCORI has a calendar in which they participate ideas from the community about important new opportunities, and then they build it into their budget and they fund particular types of things. I guarantee you there's going to be nothing that comes across PCORI that has a bigger public health benefit than the scaling of this screening encounter of the chest in heart disease, lung disease, and lung cancer. And if we as a group, with the people that have been involved in the last day or so on this, address the PCORI mechanisms about the importance of this opportunity and the idea that they can do in places that are doing annual screening, potentially in hundreds of thousands of people, you know, as we go forward, and that even capturing a fraction of this in a systematic way and kind of have a proposal along the lines with the IPF people were saying, you donate data, you get to use the data. You don't donate data, you don't get access. The gold, the most valuable thing we've been discussing is not dollars. It's cases with imaging and follow-up data through time. That's going to be how every AI tool is going to be made or broken, and all kinds of other things that we've been aspiring towards. And so if we can work with mandatory to get some kind of consortium of institutions to start building these data sets the way that David Maron has outlined, and then harvest that with pragmatic trials, technology assessments that Bruce has discussed and stuff like that. We can do this. And there's funding, very good funding to do this. And there's not any other major body in the country that has resources close to what they have at their disposal. So I think we should talk about that in more detail, because it's relevant for David's cardiovascular study, but it is a strategy that has much broader applicability. David, you've obviously given this some thought.
It's talking
I'm
to
not
you,
sure
David.
which David.
David Maron, yes.
Oh, well, my heart is full listening to
Maron.
Yeah, David, you're going down the right path.
Oh,
Is-
yeah, I'm sorry. I'm going to go on mute.
I don't think he heard us say that he was on the right path.
Yeah.
David, we're asking for your comments.
I wasn't
about
sure
the-
which David you were asking to comment, but I'll say that my heart was full listening to you. I'm saying yes. There's so much opportunity. First of all, I really resonated in me when you said this is not about money. This is about, as you called it, cases. There are so many people walking around with early stages of disease that are already could be detected by information already gathered or being gathered. They can be detected by AI to make it easier for the radiologist. There's such an opportunity to intervene early on a number of diseases where we can really make a difference in terms of clinical events and quality of life. So I couldn't agree with you more. And I hope that all of those people who are listening, who happen to be in PCORNet at one of these sites, will agree to participate in the trial that we're planning.
Well, I think certainly the trial you're planning will be very important in this. And I don't know if it's just focusing on the coronary calcium. Are there any thoughts about expanding it to some of these other things as well, or is that too much in one trial?
Yeah, the guiding principle is keep it simple.
Yeah.
We are our sample size is going to be 40,000 patients. I think that's the same as the Rubinska sample size, and we're just barely going to be able to make it financially, even though it's a very pragmatic trial. It's very hard to come in under the budget that PCORNet offers, and so there's a limit to what we can do.
Right.
So we're basically going to be screening using an electronic health record for those people who are clinically eligible, running the scans of those people through the AI program, and sending out notifications, and then at the end of the study, doing PCORNet queries to looking at CMS data, National Death Index, and some commercial claims to ascertain events. It's a really cost-effective way to do a clinical trial, but it costs a lot of money because of the number of sites and the number of patients.
So the
So David-
trial that Jim is dreaming of, I guess, Jim, you're going to have to take the lead in developing that trial.
No. We
no,
need a different mindset. Now, this is PCORNet. It's not NIH. NIH now requires all trials to develop a data plan and have an explanation for how resources developed in that trial will be made available or not, and justify what their position is. Now, I think, David, we might think about, I don't know what's actually possible, but we might think about introducing that kind of concept to PCORI, in that I understand what you just said about 40,000 the cost, and anything divided by 40,000 becomes a small number very quickly. But if you said, I'm going to use this data to do my question, but then this archive of images and other information that I have available is potentially available to be repurposed in PCORI under X, Y, and Z conditions, whatever it is that's appropriate. And that we think this should be done from now on in this space, because the urgency of tackling these cardiovascular, pulmonary, and cancer questions in the screening context, we want to start acquiring a national resource, data resource around this. And we think that after we finish our trial, this might be a first block of accrual that might start aggregating these kinds of questions to allow to become substrate for all this AI tool development that you just mentioned.
I think it's a great idea. We don't have the budget to have a repository. We're not keeping the scans. So I think it would be a separate application to PCORI. And the reason we're going to PCORI, frankly, is because they do, as you said, they have funding that NIH currently does not have for dedicating to large clinical trials. We have a much better chance of getting funded at PCORI than we do NIH. NIH right now, NHLBI, my understanding is they're funding maybe one large clinical trial per year. This particular funding cycle through PCORI will fund 10 trials up to a total of $200 million total for those 10. That's a lot more than my understanding of what NHLBI is funding currently.
But David, could we potentially envision a meeting with relevant people from this to kind of just have this conversation with PCORI about this opportunity? And by the way, Al Rizzo to my right here and I have met with the extramural staff of the NCI and some representatives from an HLBI about thinking about how they could create a strategy for leveraging these data sets coming out of screening in a more consistent way. So maybe they want to sit in and figure out if there's some kind of consortial opportunity to get these data repositories, because AI is going to change how we do business, and we need hundreds of thousands of cases in order to to make sure that we address diversity and do not unintentionally make inequities in availability of screening aspects. And so I think this is the time to kind of grab the bull by the horns and just say, hey, this never was possible before. Now it is. How can we be thoughtful, rational, and do it in a way that conforms with current possibilities?
Totally
Jim,
agree.
I think that's wonderful. I love the idea that you think this will require another application. So again, Jim, that gives you a chance to be very valuable. But I do think but David has to first get his study funded, and then we're talking about years of waiting to get these databases, and then it's going to come at the end of that. I think I still want to circle back to Bruce's idea, because it gets us a large part of the way. I'm not saying what you're suggesting is not correct. I think it's wonderful, the idea of getting NCI and NHLBI involved. I'm all in on that, and I would love to be participating, and many of the members of our LCAP consortium who would participate and love to be involved. But I also think that we should not overlook what Bruce was suggesting, that we could get Medicare data. And I think that with a conversation with our group, Bruce, David, I'd be delighted if you participated. Talk about what we could do retrospectively, take all our cases and look at these various illnesses because our database is, our cases are in a database. We could easily run software on tens of thousands of cases, and then Bruce could use the good graces of Milliman and tell us everything we need to know about the outcomes here at a far lower cost, and probably start this very quickly if we wanted to. I mean, that would be something that's really exciting, I think. That could be one of the major, objectives from this meeting, or points that we could start moving forward with all of these ideas to expedite the evaluation. So I'm very excited about all these possibilities. I think we're pretty much closing out the end of this 3-hour session on cardiac imaging. This was a lot of great stuff. Matt, are you still there? Because I just want to thank everybody for their participation.
Right here.
I want to thank everybody. Matt, you want to have any final words to the audience, to the
Yep.
audience participants, panelists?
Yeah, thank you so much for the panelists, for the presenters, Dr. Lin, Dr. Okwuosa. Thank you so much for the engaging conversations. Yeah, thank you.
Yes. Okay, thanks everybody. I thought this was a informative session. We have a lot of takeaways, things that we're going to do. And Faye, I look forward to seeing you at Mount Sinai one of these days.
Yes.
So anyway, thanks everybody. This is terrific. Really enjoyed it, and some great homework for all of us to do.
Thanks very
Thank
much.
you.
Thanks.
Thanks
Thank
for the
you. Thank you,
invitation.
Tochi. Thank you, Matt.
Thank you.
Thank you.